Okay, now let's go on to heart murmurs. We discussed the maneuvers. Let's actually talk about what we're going to hear. For all of these murmurs, we're going to discuss why they occur, potential consequences, and also listen to some of them. These are incredibly high yield because patients have these, so focus in here as we start with aortic stenosis. The problem in aortic stenosis is that there's excessive calcification of these valves. Usually it's due to old age or a bicuspid valve. Notice how there's normally 1, 2, 3 cusps, but in the case of a bicuspid valve, those two valves take more wear and tear than normal. So what's the left ventricle going to have to do? Well, it's going to have to increase pressure to a certain point to snap these stenotic valves open. This is where the tardus, or late. You ever been tardy to a class? So this is where the component comes from. How does the left ventricle feel about this increased pressure that it has to pump against because of a stenotic aortic valve? Not cool, bro. Not cool. It cannot open the aortic valve to eject enough blood. This causes a decrease in stroke volume and consequently a very weak pulse. The initial ejection is weak, right? Parvus in Latin means weak. So why is this a problem? Two reasons. Number one, we will not have enough blood volume in the aorta for adequate systemic and coronary artery perfusion. So there's a decrease in perfusion of stuff in front of that stenotic aortic valve. Number two, the left ventricle is going to have to go left ventricular concentric hypertrophy. It's got to compensate for the extra work it has to do to open the valve. So the decreased forward systemic perfusion may actually result in syncope. This is because not enough blood is going to hit the brain, right? In addition, this hypoperfusion will also lead to a problem in the coronary arteries. We have to perfuse the coronary arteries in diastole. So this combination of a decrease in overall ejection and also an increase in oxygen demand because of left ventricular hypertrophy sets us up for ischemic events. This is your patient that might present with angina. So what about the dyspnea? Well, the dyspnea can be attributed to the hypertrophy that the left ventricle must undergo to push the stenotic valve open. Over time, the left ventricle will increase its wall thickness. This thing is going to get super thick. This leads to a decrease in the compliance because for a given amount of volume, the pressure will be very high. This is diastolic dysfunction. So when the patient moves around, the heart cannot accommodate more blood in the chamber despite an increase in myocardial oxygen demand. So what happens? Well, the aortic chemoreceptors sense a decrease in delivery of oxygen. This sends signals to the brain, particularly the brainstem, saying that we need to do something about this. We need to tell our body to breathe a lot. This creates a sensation that we're short of breath, so the person starts breathing a lot. This is dyspnea. So before we listen to the murmur, let's talk about when and where we're going to listen. Here's that diagram again. It occurs after S1 and lasts all of systole, hence the term holosystolic. So the crescendo part initially means that we're coming up like this. This is due to the continued increase in left ventricular pressure because the flow is increasing across the aortic valve until we hit maximum contractility. As the pressure starts to decrease because the ventricle relaxes, there's going to be a decrescendo part. This is because of the decreased flow. This happens all the way until we hear S2. The murmur is going to be loudest here in the aortic area, right? This is because the flow vector is going like this into the aortic arch. This is towards the second, here's 1, 2, intercostal space. Now turbulent flow can sometimes be heard all the way up into the carotids. So this is a very unique murmur. Let's listen to it. One more time. The murmur is very unique because it increases as a crescendo and then starts to decrease with a decrescendo intensity. Now let's push on to mitral and tricuspid regurgitation. So these two are grouped together because they're essentially the same thing except on the left and the right side of the heart. So you can have regurgitation over a prolapsing mitral valve in situations of mitral valve prolapse, or after myocardial infarction, or due to left ventricular dilatation. This is because the valve leaflets are pulled apart. Another situation we can have is infective endocarditis or rheumatic heart disease. In mitral valve prolapse, the valve leaflets prolapse enough that blood can regurgitate back into the left atrium. In the post-infarction period, one of the papillary muscles can actually rupture, responsible for tensing the chordate to hold the valve shut during systole. So watch out for papillary muscle rupture here in a post-MI patient. Which papillary muscle do you think is most likely to infarct? How about one that only has one blood supply? We're talking about the posteromedial papillary muscle that is only supplied by which artery? The posterior descending artery. Remember, that is a branch of the right coronary artery. This would lead to new onset acute mitral regurgitation after someone has a heart attack or myocardial infarction. Now, rheumatic heart disease can target any of the heart valves because it is an autoimmune cross-reaction. Let's look at this image here. So rheumatic fever is due to autoantibodies targeting against glycosaminoglycans that are a component of all heart valves. It classically affects the mitral valve, as you can see here in this image. What about infective endocarditis? Well, infective endocarditis will usually be presented to you in a patient that has done some IV drugs, just a little bit of fun, and it's usually with the tricuspid, not mitral valve. So why tricuspid and not mitral regurgitation? Well, when an IV drug user punctures their skin with a needle, commensal organisms on the skin are pushed directly into the venous bloodstream. The first valve the organisms travel and see in the venous blood is the tricuspid valve. Just because it is the most common valve does not mean you cannot have other valves involved in an IV drug user. So where are we going to hear these murmurs and what do they sound like? Both of these murmurs occur all throughout systole. They're holosystolic murmurs. Now, mitral regurgitation is best heard in the mitral area. This is kind of confusing because the flow vector is going this way, but the thing is that the sound travels the fastest where the greatest mass of the left ventricle is, which is here at the cardiac apex. Now, what about this radiating to the axilla part? Remember, we just said that blood flow vectors also carry sound. The murmur is going to radiate here towards the axilla because that's the way the blood is regurgitating. Now let's talk about the tricuspid stuff. The murmur of a tricuspid regurgitation is best heard where the most mass of the right ventricle is located, which is directly under the sternum, around rib 5. Your murmur will be transmitted best through the myocardial wall of the right ventricle that is closest to the anterior chest wall. Just like with mitral regurgitation, the regurgitant flow vector is across the tricuspid valve towards the right atrium. Where is this vector pointing? Towards the right side of the sternum. So let's listen to this murmur. One more time, guys. Listen for that holosystolic murmur. Okay, next up is something we've mentioned a couple times, mitral valve prolapse. Again, here's this diagram we've seen that shows a prolapsing mitral valve. It's sitting in between the left ventricle and the left atrium. Of course, that's where it's supposed to be. Note how there's just so much valve tissue here compared to the distance that actually needs to be covered. Look at these redundant valves sticking up like little mountains. Now, the lines extending here from the papillary muscle, which is here, these are the chordae. They pull these valves back towards the left ventricle in systole to prevent them from billowing or prolapsing up. Now, in mitral valve prolapse, the valve leaflets are going to billow up like a parachute. This leads to the poor coaptation of valves, and there's going to be a little gap where they're not coapting. This allows for blood to flow in a retrograde manner from the left ventricle into the left atrium. So when the valve leaflets prolapse, the chordae that are holding onto them are going to all of a sudden really tightly quicken. And this creates a vibration like flicking a guitar string. We can hear this audible sound using our stethoscope, and we describe it as a mid-systolic click. So let's look at this phonogram and then listen to it and see where we would actually hear this murmur. So it is a murmur that occurs in the vicinity of the huge mass of the left atrial apex. And we know that sound travels best through solid, so you're going to hear this best in the fifth intercostal space in the mitral area. The mid-systolic click starts the murmur off, as you can see, represented by MC, and the intensity increases as more blood regurgitates as the pressure gets greater throughout systole. It will regurgitate over the non-coapted segment. So let's listen to it. One more time. So if you hear this murmur while examining the patient, what are some etiologies of mitral prolapse that should pop into your head immediately? Remember, that's what you're supposed to do as a doctor, is identify why it's happening. Well, any damage to the valve itself in something like rheumatic fever or the chordae that are supposed to prevent the prolapse can lead to this murmur. Also included on here is something called myxomatous degeneration. What in the world does this mean? This means that there's just way too many mucopolysaccharides on the valves, causing them to excessively retain water. This makes the valve very floppy, redundant, and weak. It's usually benign, but it can predispose you to infective endocarditis. Why is that? Well, if you have valves just flapping around like bed sheets in the wind, this can cause a lot of mechanical stress and eventually injure the valves. So remember that the low virulence haystack organisms are all about already damaged valves. But things like Staph aureus, they're big dogs, right? They don't care. Staph aureus will infect any heart valve. So what type of patients should you be on the lookout for myxomatous degeneration? How about patients that already have connective tissue problems, such as a Marfan patient or an Ehlers-Danlos patient? These are extremely high yield for you to always be on the lookout for because it's not only going to be important for you to identify it, but it can tie in some biochemistry. Now let's talk about a VSD. A ventricular septal defect allows blood to flow from the left ventricle to the right ventricle and then into the pulmonary circulation. Let's look at this. The murmur is going to be best heard in the tricuspid area. This is because the right ventricle is closest to the chest wall in this location and the murmur is occurring from left to right in this direction. This is a holosystolic, all of systole murmur because there's always a gradient for blood to flow from left to right in systole. How are you going to differentiate a holosystolic murmur in the tricuspid area if you're concerned about a VSD or tricuspid regurgitation? Well, the murmur of a VSD does not radiate anywhere. It does not go up and towards the right side of the sternum. Let's listen to this thing real quick. One more time, this holosystolic murmur. Okay, we're doing great, guys. Keep it up. Now we switch to diastolic murmurs. So what are two murmurs that we need to know about that occur in diastole? Well, one of them is aortic regurgitation, and the other one is mitral stenosis. Here's aortic regurg. The arrow here on the left, patient's right, shows the regurgitation of blood through the aortic valve. So this combination of regurgitated blood and the new incoming blood through the mitral valve will eventually lead to a large volume within the left ventricle. This is going to overwhelm the ventricle and it's going to progress to systolic dysfunction because it's going to add sarcomeres in series to allow for more volume expansion. Now, why would someone develop aortic regurgitation? Well, number one, we could have a bicuspid aortic valve. Wear and tear in a bicuspid aortic valve can eventually lead to it giving up and being very incompetent. Or we can have endothelial surface damage due to infections such as infective endocarditis. Or we can have our immune system attack it with antibodies directly in the situation of an autoimmune attack such as rheumatic fever. Now let's see where we would hear it and how it looks like on this phonogram, and we'll listen to it as well. You can see how this high-pitched blowing murmur is starting at the onset of S2 and then is a decrescendo murmur. This is exactly when the aortic valve closes and the diastolic pressure in the aorta is the highest immediately after it. It will continue to decrease, so the pressure gradient for regurgitation will eventually fade away and there will be none at the end of diastole. The intensity is highest at the onset of diastole and decreases as the pressure in the aorta drops. This makes sense, right? So we're going to hear this best along the left sternal border near the 1, 2, 3 intercostal space. Now, why is it that we hear aortic regurgitation in this area? It's not going to be in the aortic area because the flow vector of regurgitating blood is in this direction. All right, guys, let's listen to it real quick. One more time. All right, it kind of sounds like a robot has aortic regurgitation, but that's what the murmur sounds like. Now we'll keep on going and hit mitral stenosis. We move on to this last diastolic murmur. We have to know about this one. This is super high yield. The classic cause of mitral stenosis is rheumatic fever. This is a great time for us to review the pathogenesis and immunology behind this disease. So, what happens? Well, if someone has group A strep, Streptococcus pyogenes, your immune system is going to see this bacteria and it's going to produce tons of antibodies to bacterial antigens such as M protein, and this is a bad thing. Why is it a bad thing? Well, because M protein can cross-react and deposit in places causing inflammation, and the inflammation will eventually lead to fibrosis and thickening of heart valves. And you can even have the edges of valve leaflets start to fuse together. Let's look at this. So here's a diagram that shows us what we need to look at. Here we have a normal mitral valve with the anterior leaflet and the posterior leaflet. They come together to insert on the annulus or the fibrous ring that the valve is situated on. It serves as the base of the valve. Now, you can see how these two valve leaflets are normally going to open very easily and allow blood to go from the left atrium to the left ventricle. Now, let's look and see what happens in a rheumatic heart disease situation when we have fibrosis. So the recurrent inflammation and fibrosis will lead to thickening of the valve. Look at this thing. These commissures here are going to fuse, and notice how there's only going to be a tiny little slit available to open. We're left with this slit-like opening and limited valve motion. Note here how the valve leaflets cannot swing open. All they can do is just bulge out into the left ventricle, and there's a very small aperture for blood to flow from the left atrium to the left ventricle. These little valve leaflets pucker up, and only a tiny opening means that there's going to be high flow over a tiny aperture. This is the murmur of mitral stenosis. Let's quickly listen to it. One more time. Blood flowing over this creates a characteristic diastolic rumble. It occurs after an opening snap. The snap is from when the valve leaflets are going to bulge like a dome until enough pressure actually snaps the only tiny little mobile parts of the leaflets open. So as the stenosis gets worse and worse, you start to hear it sooner and sooner. This is not a good sign, because the closer you hear this opening snap towards S2, the more severe the stenosis. Where are we going to hear this murmur? In the mitral area. Remember, the largest mass of the left ventricle is at the cardiac apex, so sound travels best there when we're talking about mitral valve stuff. So why is chronic mitral stenosis a bad thing for the left atrium? Well, the left atrium is going to be responsible for pushing against the high afterload of the stenotic valve. This is eventually going to lead to high pressures within the left atrium. This can lead to dilatation of the left atrium and eventually the backup of pressure into the pulmonary vasculature. One important thing to remember is what structure can be compressed by this large atrium. I'm talking about the left recurrent laryngeal nerve. So watch out for a patient that has a mitral stenosis murmur described to you and has new onset hoarseness or something like that. Very high yield for you to understand that this person has now left atrial dilatation. So we've discussed murmurs that are heard in systole and diastole. Now we're going to discuss a murmur that you can hear in both situations, therefore it is called continuous. This is the murmur of a patent ductus arteriosus. What are two common reasons for a kid to have a patent ductus? Well, the most common ones are prematurity and also rubella. You need time for smooth muscle cell proliferation and fibrosis to obliterate the ductus and just leave the remnant, the ligamentum arteriosum. So if you're born early or prematurely, you didn't have enough time. Time ran out on you. Sorry about it. Rubella has a similar situation, except that it directly infects the endothelial and the vascular smooth muscle cells that are supposed to fibrose and shut off the ductus. So there's disruption of the normal contraction and closure of the ductus because there's apoptosis of these cells. Now, why is this murmur systolic and diastolic, also called continuous? Well, it's just because there's always a gradient for this flow to happen. Note how the sound gets loudest when the systolic pressure in the aorta should be the highest. It continues to increase as we get closer to S2 and then decreases a little bit after the closure of those valves. Now, where are we going to place the stethoscope to hear this murmur? Well, you're going to hear it where the ductus is, right? Directly under the left clavicle in the left infraclavicular region. So what are we going to hear when we actually placed our stethoscope there? You hear that? It literally sounds like a machine gun, right? Continuous murmur. There's always that murmur there, systole and diastole. One more time. This is a very characteristic murmur that lasts throughout systole and diastole. All right, guys, we're done with the murmurs. We have a quick flash quiz before moving on to the electrophysiology. Regarding auscultation of the heart, in what areas are murmurs of pulmonic stenosis and pulmonic regurgitation best heard? The pulmonic area, i.e. the left sternal border at the second intercostal space, and the left sternal border respectively. Got to know this stuff, guys. You're going to actually have to listen to patients' hearts, and it's really important because if you catch a murmur, you're going to really do your patient a good thing. All right, guys, keep up the good work.